This guide to using the esophageal Doppler simulator also includes hints and tips which may be useful when monitoring real patients. The probe should be placed as early as possible in patients to let a good mucus bond develop. Ultrasound travels poorly through air, so the mucus bond makes focusing easier, which is why the simulator is filled with gel. When placing the probe, hold it with the beveled edge facing up and slowly insert it into the nose. As with any nasogastric tube, please be aware that nasal insertion is contraindicated in patients with nasal polyps or injury, facial trauma, or in situations where there is potential for injury to the brain. Insert the probe until depth marker 3 is at the simulator's nostril. Marker 2 is the starting point for oral placement in a patient, unless they are exceptionally small or tall. Connect the probe to the EDM Plus and enter the simulator's age, weight, and height. The EDM Plus uses these parameters with the nomogram that calculates stroke volume from stroke distance. Age has the biggest influence on this nomogram because normally the descending aorta increases in size as people age. Patient characteristics outside of the nomogram's limits appear in red when entered into the monitor. In these instances, volumetric calculations cannot be made. However, stroke distance, which is the area under the velocity-time Doppler wave, can still be used for guiding fluid and vasoactive drugs. Once patient data has been accepted on the EDM+, the Doppler signal appears on the screen ready for the signal to be focused. In a patient, slowly rotate the probe through 360 degrees. If you do not see the signal, withdraw the probe by 1 centimeter and rotate slowly through 360 degrees in the opposite direction. This change in direction reduces the torque on the probe spring so that when you find the right signal, the probe will not drift off as it unwinds. Keep withdrawing the probe by 1 centimeter until you find the correct signal, changing the direction of rotation each time. The esophageal window to the thoracic descending aorta is usually found at T5 to T6 in patients. This is positioned around marker 3 in the EDS, so only small rotational adjustments should need to be made. We detect the waveforms from different blood vessels by adjusting the depth of the probe. If we slowly remove the probe until depth marker 1 is around 2 centimeters below the nostril, you should observe a wave below the white line. This is the pulmonary signal. Now move the probe until marker 2 is close to the nostril and you will detect the intracardiac signal. This is a good indicator in a patient that you are searching in the right area and that you should investigate further, initially by rotating the probe. If you continue inserting the probe slowly until around 1 centimeter beyond depth marker 3, you will see a venous signal, which is displayed below the white line. When you see this in a patient, it indicates that the probe is too deep and you should withdraw and refocus. If you return to marker 3, you will see the optimal signal. The best signal will have a strong orange and white edge, with a trailing white edge and a dark center. It will always have the loudest, sharpest whip-crack sound. You may need to adjust the gain on the monitor to improve clarity of the image depending on signal intensity.